So just to let you know, doctor, I checked the YouTube now and it's working perfectly.
Okay, thank you.
Okay, so I'll just leave now.
Okay, thank you.
Do you need anything from my side? If you need anything, just let me know.
Let me quickly share the screen.
Yes, and I will check it also on YouTube.
It's okay as well. Can you see my screen, Fadi?
Yes, doctor. I can see it in Zoom and in YouTube as well. It's perfectly coming. As discussed earlier, there is on Zoom, there are about 10 seconds delay. So just mute your YouTube window so it's not interrupted or anything by the voice.
Yeah, it's muted. Okay.
Perfect.
Thank you. So I'll start in 2 minutes. You can leave now. Thank you so much.
Okay, thank you.
So it's 3 o'clock. I think I'll start the presentation. Welcome to all of you who have joined the session. I know it's short notice, but I had some time, so I thought I'll discuss a very important topic, which is minimizing interventions in neonatology. So an intervention is any action taken to improve a medical disorder, and it can be medical and nursing interventions. We have varied approaches to the same problem. So the same team, different members of the team may act differently. Some of them may have an aggressive approach to management and some have a conservative, and there may be others who follow a medium, which is in between the two, depending on the situation. So in this presentation, I want to have a clear overview of various interventions that we do. Is there any advantage of minimizing interventions and what advantages are there? And we will look at 3 different aspects: clinical interventions, procedures, and developmental care, and how minimizing intervention or improving intervention in each of these aspects will help the patient care. Why should we minimize interventions? So there are benefits to the patient as well as a benefit to the team. For the team, the lower complication rate, possibly due to reduced infection and complications, may lead to better outcomes. There is also a general feeling of well-being in the team when we are able to achieve good results with better patient satisfaction and less procedures done. There is a saving on the nursing as well as the doctor's time by reducing the procedure time. This is a big saving in terms of workload. You're saving the time for nurses, doctors, and also saving the baby pain. Significant cost savings, especially with DRG coming into force everywhere. The more frugal you are with your expense, the more saving you have for the hospital. For the patient, obviously, less intervention means less handling and lower risk of infection. Remember that most of our procedures involves pricks and breaching the barriers. Even a benign intervention like inserting a feeding tube or suctioning has a risk of bacteremia from mucosal injury. A baby who has less handling and less intervention may have less pain, better sleep and rest pattern. So we stop thinking really of the baby as an individual. We start looking at them as patients fully. So they are with us for 2 months, 3 months, or even longer, and we have to support them, normalize their care as best as we can. So early developmental care and NICU are the interventions which I will discuss towards the end of the talk. It has been shown that less interventions, less infection leads to better outcomes as well as shorter length of stay and lower bills. It has benefit for everyone. So is there any reason that people may over-intervene for any reason? I mean, one is defensive practice. So you want to be safe, or the myth that you have to be safe by doing more intervention. So it's not easy to find the balance, but inexperience plays a role in that. Knowledge gap may play a role as well, and the lack of confidence. So what if I don't do this test and the baby happens to have infection? What if I miss something that is there in the blood report? And so this thought makes you do more and more. But a reasonable level of judgment is important, and experience. You gain experience as you start doing more conservative practice. So it doesn't come automatically, and you have to try your best to try reduce interventions. Think about every test. We will be discussing those as we go on as well. In some settings, you may have incentivized practice or financial reward for overdoing. Unfortunately, the hospital gets more money if you're paid by every test. The DRG-based system or the diagnosis-based payment system has kind of taken away this incentive for the hospital, so people don't put pressure on you to do more tests. But in the background, you have to keep that in mind. One of the reasons, one of the things we have to focus on is not to separate the mother and the baby. So bringing the baby to the NICU unnecessarily has to be avoided, where the care can be delivered safely by the mother's side. The other important aspect is not putting too much thought. So whether I really need a test at this stage, do I need it immediately, or can it wait for the next day? And some units have a hard-driven protocol. So you need to do bloods on Monday, for example, for all the babies below 2 kilos. You need to do gases every 4 hours on ventilated patients. Blood sugar monitoring continues for a long time on babies on IV fluid without reducing the frequency, and so on. So any protocol is a backup, and it's always good practice not to forget things which are important. So have a plan that is written down, that do bloods with the next cannula change, or do bloods within this period. So if you're having anything else to be done, you combine them together. So not on a particular day, but individualize according to the baby's needs. So the different types of interventions can be procedures like cannulation, line insertion, intubation, and radiologic investigations like X-rays, CT, MRI, barium studies, transfusions, respiratory support related interventions like surfactant administration, invasive, non-invasive ventilation, intubation, chest drain, and so on. And medication related interventions, which can be oral medication, intravenous medication, and so on. So again, even when it comes to medication, you need to think about the route of medication. When can you change to the oral medication? Because intravenous medication carries a higher risk to the baby. And if you don't have any other venous access, using the IV access or central line access to give medications increases the number of times you're handling the line as well. In terms of nursing intervention, you have routine care, suction, and feeding, and interventions which are positive, which is targeting the developmental care. So Kangaroo mother care without doubt is beneficial for the babies as well as the family and the nursing team. Parent interaction, make them aware of the baby's needs, involve them more in the care. So NICU involves a lot of parent interaction built into the system. and developmental care measures and pain control. We shouldn't forget pain control measures, because a baby who is having pain is scarred for life. So if you don't minimize the number of painful procedures, if you don't think about pain control measures, you're actually damaging the development of the baby. A couple of quick case scenarios. So we have a premature baby, 29 weeks gestation, 1.1 kilo, day 3 of life on mechanical ventilation for respiratory distress. So this is a example. I mean, you can fit any case into this example. So this is the start of the nursing shift at 7 a.m. and the nurse hands over at the bedside. The nurse who has just taken over reviews the setup at the bedside, and she feels the baby is better supine as the baby was prone for the past 2 hours. She handles the baby and turns the baby supine. A few minutes later, the saturation alarm goes off and she suspects loose contact and tightens the strap on the probe. The baby desaturates again after a few minutes. She's not sure it's a probe, so she decides to suction the baby. The baby was due to be given a trophic feed at 7:30 and she gives the feed. At 8 o'clock, the doctor's handover at the bedside. The nurse mentions the desaturation. The registrar decides to listen to the air entry and perform cold light to make sure it's not an pneumothorax. So they have done 2 steps of the dope. They have done suction and they have done cold light to rule out air leak. After a couple of minutes after checking the cold light, the doctor asks to check the blood pressure again. The nurse repositions the cuff to another limb and checks the BP. And the doctor discusses with the consultant over phone, who feels it's better to perform the chest X-ray and also to review bloods to rule out sepsis. The nurse takes the blood sample by venipuncture and sends it to the lab. The chest X-ray is done in another 10 minutes or so. When the consultant examines the baby and reviews the chest X-ray, the tube is a bit deep. So it's obviously another aspect of the dope, which is the tube displacement. The first step was missed. So they have gone on to further steps, further investigations, when a simple tube adjustment, possibly when the nurse turned the baby supine from prone, the tube might have pushed in. The registrar adjusts the tube, but then after a few minutes, the nurse realizes the baby needs a gentamicin level to be sent at 9 o'clock. So she again pricks the baby to take a blood sample. So a blood sample was taken at 8:15, which probably was not needed. It was a tube position related desaturation. And again, there is a prick at 9 o'clock. So this is not uncommon. It happens in almost every NICU, and it's not intentional, but people don't put enough thought into what we can do to reduce interventions and streamline the work pattern. So a lot of responsibility for this is in the team mentality, team mindset as a whole. The nurses play a role in cohesing this, and the doctors have a role in respecting and supporting the nurses' role. So this baby had 14 interventions within a 2-hour period, and leave alone the disturbances caused by the sound, the alarms, the people talking near the incubator. So these will, if you consider that as an intervention, it will be even more. This could be reduced by better collaboration between the team members to reduce handling the baby, better awareness of the tests pending on the baby, so clustering could be done, and clear communication between the team members, so plan of action is clear. So follow the steps of dope, for example, in this case. So if the displacement was picked up in the very beginning, you may not have proceeded to the other steps. So should we be concerned about increased intervention? So reducing handling, as we discussed before, could improve infection control, better physiologic stability, allowing the sleep and state variations. And this itself improves the immune response of the baby. It may improve the growth of the baby. They better assimilate their nutrition. A constant stress level increases their inherent steroid level. So you may have fluctuations in the blood sugar. You may end up monitoring the baby sugar more often, and that very fact may cause further stress and increase the blood sugar more. So hyperglycemia can happen as well in these babies. In the early stages, intraventricular hemorrhage risk is also there due to excess handling. Cost saving we mentioned, and possibly better outcome. I wouldn't say possibly, but it's almost definitively better outcome. An infection-free course is almost an intervention-free course. A stable baby has minimal complications. So we are just supporting the physiology, making sure the baby adapts and supports through the course. Sepsis leads to complications that necessitate more intervention. So you may need ventilatory support, more blood sampling related to blood gas monitoring, infection marker handling, and so on. The baby may start having feed intolerance or suspected necrotizing enterocolitis along with the infection. So you have periods on total parental nutrition. You may need central line for longer periods of time or even surgical intervention. The transfusions that are related to having a sickness level, frequent sampling, losses due to sampling, hemolysis due to sepsis, and thrombocytopenia, they lead to increased transfusion risk. And eventually, a sicker baby has a high cytokine and inflammatory mediator response, and they need more ventilatory support as well. So there is a higher risk of BPD, which lengthens their hospital stay. There is a higher risk of poor growth and increased length of stay. So in this case scenario, we have a 28-week baby who is 1.1 kilo at birth. The baby had a stable respiratory status, CPAP for the first 4 days, high flow for 7 days, and then self-ventilating in room air after that. Just received ampicillin gentamicin at birth, which was stopped at 48 hours. We are now stopping antibiotics at 36 hours in many babies, as our microbiology lab has supported us and reduced the turnaround time. The UVC and TPN for 5 days. The baby reached full feeds by 6 days. There was enough EBM available. The mother had good counseling in the antenatal period. She started expressing from the word go. A very motivated mother. Skin-to-skin care was started early, and there was no feed intolerance subsequently. The baby actually went home at 7 weeks of age at exactly 35 weeks corrected gestation. The weight was 2.1 kilo. No chronic lung disease, normal brain scan, no ROP, and no further episodes of infection. So this is an example of a smooth course, and that happened only because the baby did not get infections during the course. The hemoglobin was 9.4 grams at discharge, and the reticulocyte count was rising. So baby did not need a transfusion either, and hemoglobin was increasing at follow-up. So we do get such babies in between, whether it is luck or it's just the prevention of infection being successful in that particular baby remains to be seen. So on the other hand, we have this baby, exactly same weight and gestation. Baby had RDS, needed CPAP in the beginning, was stable till day 5, was on ampicillin gentamicin in the beginning as well. Umbilical venous catheter insertion failed, and baby had another intervention with the central line inserted. On day 5, unfortunately, baby started developing multiple episodes of apnea and vomiting. The baby had reached only 2 ml of feeds, as there was some feed intolerance prior to that. The CRP was raised, and baby was started on vancomycin and gentamicin. Baby was ventilated in view of repeated apnea and stayed ventilated for another 5 days due to poor effort and the CRP being high. The baby was kept off feeds, and TPN was continued for this period. The CRP was reducing, and the blood culture grew coagulase negative staph. Before the blood culture itself, the lumbar puncture was done. It was suggestive of not suggestive of meningitis. The cranial ultrasound at that stage showed a grade 2 intraventricular hemorrhage, and this was stable on follow-up. The baby restarted feeds on day 10, and after 4 days developed distension, increasing aspirates, and suspected NEC. So remember that dysbiosis is very important in the etiology, and stress is an important factor as well. So when you are altering the natural progression with continued antibiotics, the infection that happens and the antibiotics that you use as a result of that leads to dysbiosis, and that increases the risk of necrotizing enterocolitis. Of course, the hypoxic episodes, the need for ventilation, everything links up. So it's not one factor, it's all multifactorial, but one leads to the other. So it's not straightforward. The baby was kept in PO for 5 days as a stage 2 NEC and restarted feeds. Finally, the baby was weaned off CPAP to high flow, and because of BPD needed high flow till day 60 and then weaned off as well. The baby unfortunately had stage 2 plus disease in both eyes, treated with Lucentis injection twice for the ROP. This subsequently resolved. And because of the BPD needed nebulized budesonide as well, and had some reflux. But the baby is establishing feeds and is growing when there is reflex overlapping as well. So sometimes you may need, we don't use domperidone for reflux anymore, and we try to avoid medications for reflux as a whole. The baby received a total of 24 days antibiotics during the stay. So you can well imagine the impact of these on the baby's course. And of course, multiple intensive care days in terms of category of care. So these two courses show how much sepsis and infection impacts and increases the need for intervention. So when you are in a smaller unit, when you don't get sick babies that often, it's much easier to avoid infection fully. But when you're in a busy NICU, when the number of sick babies you get is very high, some infection does happen because of the number of procedures that are needed, but we can minimize it And any effort that we do to prevent or minimize infection is well worth the effort. Hand hygiene is a very important part. We should stress on the use of hand gel. A team culture where we point out to each other, respect each other, and encourage each other to follow all the hand hygiene measures is important. The care bundles have made a big difference, and care bundles for procedures like central line insertion is very important as well. It's important that we don't run into the monotony of doing the care bundle tick box exercise. So we should be doing it in a serious fashion, and we should try to achieve the real aim why the care bundle is designed. So if you have a second person to supervise, they should really be looking at it seriously. And the feedback to the person doing the procedure for infection control should be done promptly and immediately. We should minimize the handling of the central lines. I mentioned not to disturb the central line frequently for medication. Unfortunately, these are tiny babies. It may not always be practical to have a cannula every time in addition to the central line. And a closed system is important, but follow strict aseptic precautions. Try to cluster the timing of handling of the lines and move to oral antibiotics as quickly as possible. Preventing infection would mean that you come off the central lines quickly, you tolerate feeds better, and you do better. Rational use of antibiotics. So don't use the broad spectrum antibiotics unless it's essential. Stop at the earliest possible if there is no clear signs of infection. And having an active antibiotic stewardship program in your unit would help. So in terms of medical interventions, it's good for the team to plan clearly for the day ahead as the investigations procedures which are needed together, so we can adjust the timing of the tests that are done. It doesn't need to be done by the night shift staff before the handover. So it can be done by the day team as well. If there is a test like a drug level which is due in the afternoon, you can postpone the electrolyte levels to the afternoon. The TPN can be adjusted based on the blood gas, or you can modify the TPN up to a certain period of time during the day. Think about every test you're ordering and have some meaning. If you are having a bone profile on a certain day, don't do the metabolic profile on a different day. Try to club them together so you don't need to repeat the tests. Avoid ordering the tests which are having no clear indication or benefit. Stool calprotectin is an example where we don't know how to deal with it. Same with the clotting factors in a very premature baby. Unless there is a need for intervention, don't do it routinely. And remember that every blood sample saved is going to reduce the number of transfusions that are given. As I said before, avoid protocol-based testing. Have a basic protocol in place as to the number of days you want to have blood tests in, so you don't miss out on tests, and keep noting that down in your plan so you can have the test done as suitable. It's important to titrate the number of blood gases based on the clinical condition. So don't keep a set order. If a baby is on high frequency, you need it every 6 hours. If the baby is on conventional, you need it every 12 hours and so on. So titrate it. If you use other parameters like the end-tidal carbon dioxide, pulse oximeter, and if you have the transcutaneous carbon dioxide, it's useful as well. If you need a repeat blood culture planned, combine it with the cannula change, because these babies need cannula regularly for duration of antibiotics, and it's much easier to draw the blood culture through a cannula and time it with that, because if 1 or 2 days delay is not going to matter in these cases. You just want to confirm that the culture is clearing before you stop the antibiotics. And try to combine the blood tests and blood gas with blood glucose monitoring unless either one of them is urgent. Show the presence of mind and take samples with cannula change. Suppose you have a sample planned for the morning, but you have a cannula change at midnight. You don't need to prick again in the morning. So take the sample a few hours earlier. Most of the medical team is going to understand this approach, and you can make it clear when you discuss with each other that this is the reason this has been done. So there is no need for misunderstanding or fear of what will happen if the test isn't done at a certain time. So you also know, and that's why educating the nurses and empowering them is important, that they know why a test is being done, whether there is flexibility in the timing and so on. So the end-tidal carbon dioxide is a simple device, and you can get the carbon dioxide reading. It doesn't correlate exactly, but same as a transcutaneous bilirubin, it gives you a trend, and using the trend along with the saturation, you may be able to avoid. All that we need is to know the baby's ventilation is stable, and you don't need to repeat a blood gas immediately. And that information can be obtained from this. So the drug level is something that gets missed when you plan your routine blood. So try to remember the time of that so it can be clubbed with other samples, or rather the other way around, the other samples can be clubbed with the drug level. When you're taking samples, it's often a problem with blood counts that the blood count samples get clotted. And that is because you leave it for the end. When it is free flowing, take the CBC samples and ensure adequate mixing as you sample. So you don't need to prick again just because it got clotted. If the test does come clotted, discuss with the team, do you really need a repeat immediately, or you can wait for the next sampling. Avoid excess squeezing because it causes more hemolysis. Warm the heel with a heel warmer before sampling to avoid errors from the high potassium. The result, again, if the high potassium comes, the lab is having an automatic response to request a resample, but you can look at the trend before that, urine output of the baby. If there is no concern, you can wait, and next time you can be sure that you take a non-squeeze sample. Endotracheal suction is not done routinely in most units. They do by clinical care based, but always assess for the need for endotracheal suction before the blood gas sampling. No point doing a gas and then saying, oh, my baby has secretions and the carbon dioxide could be high because of the secretions. Then you end up repeating it again because you're not sure if it's just the secretions or you're missing anything else. So try to do the suction before a gas is due rather than after. And reducing the sampling loss helps to reduce transfusion as well. So the heel warmer, and remember where to do the heel prick as well, the important part. Avoid squeezing continuously. Releasing it is very important for the blood flow to come back so your sampling is effective. In terms of central lines and umbilical lines, consider the indication clearly before they are inserted. The umbilical arterial catheters are not needed routinely in the relatively stable premature babies over 29 weeks. 28 weeks and below, you may consider both. The 29 weeks and above who need just the umbilical venous catheter, you could consider putting a PICC line because the number of manipulations of the PICC line is less, usually the number of X-rays to confirm, because sometimes the UVC course is not predictable. And capillary blood gas is adequate in most situations if you don't have the UAC. Remove the lines and cannulas with clear consideration and balance the need with not leaving them unnecessarily. So even a few hours matters in terms of keeping the lines without a need. In terms of radiological tests, order the X-rays after adequate consideration of the need for X-ray and consider the timing carefully. Avoid the CT scans. High radiation exposure is there, as we'll show you in the next slide. And don't use CT unless it's no other option, like you have MRI, prefer the MRI. If you can manage the ultrasound, even better. Have a clear protocol for approach to radiologic investigations. Avoid high radiation tests like CT scan. And don't forget that the GI contrast studies are also high radiation tests. So this gives you in millisieverts the radiation dose. So chest radiograph has 0.025 and 4 chest X-rays, for example, will be 0.1. And just compare that with X-rays of other parts. And when you go to CT scan, it becomes 2.6 for the head CT, which is like 200 X-rays, more than 200 X-rays. And you have GA contrast, which is quite high, so more than even a CT scan. This is because the radiation dose needed for the gastrographin and so on increases the load and the number of X-rays that are repeated with that increased setting as well. So don't take a GI contrast study lightly. It's very important to have a team culture which allows flexibility. So the nurse should not be afraid of the doctor, for example, and the doctor should not be threatening the nurses for why you didn't carry out my order. If there is a reasonable explanation for that, just delaying the tests or postponing it to club it with other tests is quite acceptable. And accepting capillary gases instead of arterial samples, depending on the situation. If you get an abnormal lab result, think about the timing of the repeat, consider the entire clinical picture and repeat it if needed. So don't go knee-jerk just because the lab called that you need a repeat. You need to send the repeat immediately. Instruct the team not to routinely repeat X-rays just because the X-ray is not positioned very well. If you get all the meaningful information you need from that X-ray, you don't need to expose the baby to another radiation. It's not just the radiation exposure, it's also the plate that goes under the baby, how you clean it, the risk of infection from an external person handling the baby again, and so on. If the cannula is lost a dose or two before the planned, if all the parameters are normal, remember that the courses that we prescribe are arbitrary. There is no clear evidence that one dose less or one dose more is going to make a difference. So you can review the situation and decide accordingly. There is no medico-legal implication of these if you are documenting clearly that the baby is clearly safe. You have been monitoring the CRP, you have a repeat culture which is negative and so on, or the trend doesn't suggest a real infection, you're treating more for precaution. Transfusion of blood products is important to be putting in a lot of serious consideration because it's a valuable resource as well as you're exposing to human products and the risk of introducing infection. The unit should have a clear protocol to define the cutoff for transfusion. So in addition to reducing sampling, minimizing sampling losses, supplementing at the right time, and having not too conservative but not too lenient threshold as well. So now the semi-conservative approach is what is practiced in terms of packed cell transfusions. Platelet transfusions, again, depending on the situation, you have to titrate the cutoff. And if the baby doesn't respond and is clinically stable, but the platelets continue to be low, you may even have to accept lower levels and otherwise. And there is no real need to give fresh frozen plasma as a volume replacement in most situations. As a correction of coagulopathy, you may consider that. And IV immunoglobulin for preventing sepsis has no role. And for jaundice as well, you only use it to tide over the risk of exchange transfusion. In terms of respiratory support, early non-invasive ventilation, minimally invasive surfactant therapy are the ways to go. If a baby does need invasive ventilation, aim to extubate early. Avoid using routine sedation. We often underestimate the effect of sedation. Sedation, especially not only the pain relief, but using midazolam, etc., deep sedation or paralysis, causes a significant shift in different parameters. So you lose the baby's automatic PEEP through the endotracheal tube, but the baby's effort to clear the secretions is totally lost. There is more secretions, more need for suction. There is a third spacing of the fluid in these babies. Edema comes in. You lose the effect of the diaphragm in supporting the breathing, the chest wall muscle tone in maintaining the compliance. So you're losing so many parameters, and so you end up needing more ventilation. There are many studies which show that using sedation has both short-term adverse effects like needing more ventilatory support and long-term effects like delayed extubation and even impact on neurodevelopment. So think carefully and use deep sedation only for very minimal times once the baby is stable, and consider the impact of these medications on blood pressure. So because you're giving deep sedation and third spacing and pooling, etc., you may need more inotropic support, and inotropes are not safe either. So any additional medication has impact on your system that you don't see. Another example of medications where we don't clearly know the impact is the diuretics. So when we use a diuretic, there is no clear evidence that the diuretics work. At the same time, you may end up causing electrolyte disturbances, and you may need to monitor their blood tests more carefully. Because of that, they don't gain weight well. Then you start doing more interventions for the weight gain and so on. So use diuretics for 1 dose or 2 doses at a time if needed. So BPD doesn't change anything. Avoid using diuretics for a long period of time. It's more a habit than a benefit. In terms of suction, avoid routine suction. Teach the nurses to look at the ventilator graphics. Avoid routine blood gases. Do gases on non-invasive ventilation only as needed. And end-tidal carbon dioxide monitoring can be used. When you are ordering a blood gas, think about whether it's likely to change your approach. The baby is in 30% oxygen, is comfortable breathing. Are you going to re-intubate the baby? No. So you don't need a blood gas for that. I mean, you may do once in 1 to 2 days, and we often move to once in 3 days on babies on CPAP, for example. Clustered care is often practiced, and the nurses have a big role in ensuring this happens. The parents' visit also can be timed according to that, so we don't settle the baby and then the parents come and they start taking the baby out. Even though skin-to-skin care is better, you're disturbing the baby who has just gone to settle down. So try to coordinate with the parents as well. Try to avoid handling when the baby is sleeping. So if a doctor is rounding and the baby is sleeping, try to avoid examining and come back and examine again. And we mentioned suction already. Routine checking of gastric residuals, it's a controversial topic and no one really advocates it these days. If you are performing, you can do it along with checking the position of the tube, but at the same time, don't be aggressive in holding back the feeds, because advancement in feeds is important to reach full feeds faster, reduce the number of central line days, And obviously, there is no evidence that mild residuals need to be acted on. If it is significant, of course, you would be looking at other parameters like handling, distension, and so on, and then review the baby accordingly. In terms of stimulation, I mean, it's not just the procedures and the pain. They're also having lots of sensory input. The exposure to stressors in the NICU was associated with regional alterations in the brain structure and function on functional MRI. Preterm babies have 70 to 100 episodes of handling in a 24-hour period, especially in the first few days. So we really don't think about the number of episodes that are done for handling. And most of the premature babies get 16 painful episodes in a 24-hour period. So this could last well into the second month of the stay in case of an extreme premature. So it's almost 16 times 60 days. So and then it doesn't stop, it continues as well. So you can very well understand the oral aversion, the emotional withdrawal, the autistic spectrum risk that happens in these babies as well. So there are so many changes which happen in the brain during the critical period they are there. So the axons and dendrites are developing, synapse formation, glial cell proliferation, and the myelination is just starting to form when they reach full term. And this apoptosis is affected by many of the parameters we face, like hypoxic ischemia, cytokine proliferation, and so on. And very important that we nurture the brain in a careful way during the crucial period of development. So it comes to early developmental care, which utilizes a range of medical and nursing interventions, the aim of which is to reduce the stress of premature neonates in NICUs. And it might range from simple interventions like light and noise control, positioning, or non-nutritive sucking to the complex knit cap measures. So the knit cap is more complex because it individualizes to a particular baby's needs, and it needs training for the person administering it. So Dr. Als in Boston Children's Hospital suggested that we may try to understand what the infant expects as an individual for comfort, well-being, and a sense of security, which is very vital for a healthy development. And in the NICU, the babies are exposed to bright lights, cold temperatures, loud sounds, lots of tubes, and experience of discomfort and pain, as I explained on a really repetitive basis. The synactive theory mentions the interdependency and regulation of the 5 behavioral subsystems. So you have the autonomic system, motor, organization of the state, attentional or interactional, and self-regulatory. So the more the parents are involved, the more attention and consistency of care the baby gets, the better their states are organized. You allow them to go through sleep phases, REM sleep, non-REM sleep, and the self-regulation is most important, and the pain control helps with autonomic regulation as well. So the assessment tool in NITCAP is a formal and repeated observation of the infant behavior before, during, and after a care. And based on this observation, you plan your intervention. So the developmental goal for each infant will be defined according to their skills and weaknesses. The individual caregiving plans and environmental adaptations include non-nutritive sucking, allowing the baby to hold on to things or grasping, appropriate positioning, using boundaries for support, kangaroo mother care, and so on. And here parents are considered as the primary caregivers. A collaboration between the parents and the caregivers reinforces the individualized care. So this involves accurate clinical evaluation, integrating the infant behavior, assessment of pain and stress, family-centered care, couplet care of the mother and the baby dyad, breastfeeding and kangaroo mother care, organizing sleep, which means we are aware of when the baby is likely to sleep and cluster the interventions avoiding the sleep time, supportive patient-caregiver relation, hospital humanization and patient empowerment, and nursing empowerment, I would add here, and tool for change as well. So it's very important that we practice these values and practice supportive medicine for early developmental care. Kangaroo mother care has been well established and has been shown to have numerous benefits. It favors development, breastfeeding, and sleep pattern. Early developmental care has implications for numerous behavioral and physiological responses, including the expression of emotionality. And animal studies have shown that the outcome is much better, reduced stress response in the babies who are having grooming and licking mothers. So epigenetics plays a role, and this has a lifelong impact on their stress level and reactions. Most NICUs are applying some elements of early developmental care. So we need to review our practices, support these as best as we can. And Kangaroo mother care, parental presence, and education of the parents, empowering them, changing the NICU design to support this, and strategies for pain and stress management. So we should think about noise levels, should think about relieving pain. Relieving pain doesn't mean use of sucrose all the time. It means you think of measures which can reduce the pain, including reduction in the number of painful procedures. So this is the dyad or couplet that we need to achieve: a peaceful mother and a peaceful, happy baby. To summarize, neonatology is a complex field. We deal with very fragile, sick babies. What we do has an impact on them for life. So we should be carrying that responsibility. We are producing future citizens, and their behavior, their emotional soundness, and everything will be affected by what we do. And they have a lasting impact. What we do has a lifelong impact. We should minimize the interventions where possible. It should be part of your team building exercise that we discuss with each other and build it into your unit's work culture. So with this, I'll stop the presentation, and let's see if you have any questions. If you have any questions, please enter it in the chat. So if there are no questions, you can still comment and we will try to answer. With this, I will